Uh, Good morning, friends. I am Dr. Prahlad, consultant arthroscopy surgeon at Preeti Hospital, Madurai. So I thank Dr. Ashok Sham for this opportunity to present my interesting case on distal femur fracture with multi-ligament knee instability. So this is an interesting case of a 32-year-old gentleman who presented with road traffic accident, polytrauma, head injury, and he had a comminuted distal femur fracture of the right side as well as left side PCL avulsion injury. So if you see the fracture pattern, it is a multifragmentary C3 type fracture. So here on the right side and the left side, there was a PCL avulsion, a big chunk with minimal displacement. So this patient was planned for open reduction and internal fixation of the distal femur fracture. It was fixed with a dual plate and bone grafting was done after 6 weeks. And this opposite side was fixed with the open reduction internal fixation with the screw fixation. So at the end of 1 year, the fracture was healing well, and this patient did a good rehab and he got complete range of movement. But he presented with a problem of knee instability. So you can appreciate there is a tibial sag here. There is anteroposterior drawer, which is grade 3 positive here. So this was done evaluation under anesthesia, and you can see he was also having a varus instability at 0 degree as well as at 30 degrees knee flexion. So this confirms the diagnosis of ACL, PCL, and PLC clinically. So what are the challenges here? Do we have? How do we confirm the MRI diagnosis? Can we take an MRI here, or do we need to do something else? When we have to assess whether the fracture is united, can we remove the entire implant or we have to do a partial implant removal and then plan for the reconstructive procedures. So also this patient had a kind of peripheral dysvascular limb. So taking a peroneus graft was also a concern in this patient. So keeping this in mind, we thought of doing a stress radiography for him, and which is well established means of getting a clinical diagnosis. So we did a posterior stress view, so we can see the exaggerated posterior tibial translation, and also we did a varus and valgus stress view, and we can see that there is an opening on the varus on the lateral side. The scanogram was done, which showed no gross any bony alignment issues. So we decided to go ahead with a soft tissue reconstructive procedure without any bony procedure. So how to get your tunnels? So we know that this will be the direction of the tunnels. So it is very important to know whether the screws will impel your procedure. So we thought of doing a debulking of the screws and implant. So we removed the medial plate, we removed the lateral screws, replaced with just couple of anterior screws. We plan to retain the lateral plate as it was just 1 year since the fracture and it is still uniting. So what are the graft options? We took both hamstring grafts from both the sides, and also the quadruple semi-T was used for ACL. It was 9 mm, and three-stranded semi-T and gracilis for PCL, which was almost 10 mm, a good graft for PCL, and the gracilis with fiber tape was used for PLC Larson's procedure. So this is the position I prefer to do ACL and PCL reconstruction, the supine TKR position here. So these are our standard portals, viewing and working portals. Apart from this, we have several other portals to take. So this is diagnostic arthroscopy, so which showed there is a slack anterior and posterior ACL, which was just few fibers which were there. So we tried to retain those fibers and try to secure our posteromedial portal here. So we went, removed the septum, transseptal to visualize the posterior aspect of the knee, and we secured a posteromedial portal here. So this is the most important part of the surgery, to get a very good posteromedial portal. So since the knee was very open, we were able to manage with only single posteromedial portal, and this is the ACL femoral tunnel, which is done by inside out technique as a standard ACL tunnel. And we team the femoral tunnel here and keep a shuttling suture in place. So we have retained the PCL at the femoral insertion. So it helps us to keep the landmark for the PCL. So normally it should be as superior as possible, as close to the anterior cartilage. So this is inside out femoral PCL tunnel, which is well done. So now you elevate the posterior and you get your PCL tibial tunnel here. And once the PCL tibial tunnel is made, you do a anterior tibial ACL tunnel. So once all your tunnels are done, so you clean the mouth of the tunnels so that your graft doesn't get impaled in between. Keep two different suture material shuttling for two grafts of ACL and PCL. So I first transfer the PCL graft here. So here always keep in mind the killer turns at the tibia. So you can keep a Wissenger rod, and also there will be a killer turn at the femoral mouth. So you have to guide the graft inside, and both ACL and PCL grafts are now railroaded, and they are fixed on the tibial side using a bioabsorbable bio screw, and you can see the graft is well taut here. So this was the sequence here, and we did a femoral. We passed both the grafts, but before tightening on the femoral side, we did a Larson's modified Larson's technique here using Gressalis and fiber tape. So we first fixed the PLC, PCL, PLC, and then ACL on the tibial side. So this was the X-ray post-operatively. So you can see the tibial tunnel, the ACL and PCL tibial tunnels, and also the femoral tunnels. So they were escaped the implants and got a good position. So here it is very important. You can use the C-arm during your intra-op. One should not shy away from having a C-arm during this procedure in your initial phase. So this is at 1 year follow-up. This gentleman developed good, he regained his tibial sag, and good anteroposterior and mediolateral stability was obtained. So you can see his functional outcome has significantly improved from the previous. He's got complete quadriceps, active SLR, and good functional range of movement. So here again, post-operative rehabilitation is very important. We have to protect the patient in the long knee brace for initial 4 to 6 weeks, and then initial isometric strengthening exercises, non-weight bearing for 6 weeks. You can use PCL dynamic brace. We do a indigenous, we give a posterior bump on the tibial side so that there is no, it can avoid the tibial sag in the initial 4 weeks. So then you progress with a resistant and strengthening exercises and do a good rehab for a satisfactory outcome. So we did a few literature research, and we were able to see that there is a good amount of literature which shows that knee instability are always associated with distal femur fractures. So it is one has to up to 30% injuries of reported cases of knee instabilities are there. So one has to identify them and so for this, it is important once you fix the fracture, you check for the knee instability. This paper, again in Injury Journal, has shown that the various pattern of instability in distal femur fractures. This is our own paper of floating knee injury. We published a conglomerative comprehensive classification for floating knee injuries, and we have brought in this M2 modifier, which is an osteoligamentous disruption around the knee during these injuries, because these are the one which presents with instability. This is another ongoing study where we analyzed 595 cases of fractures of femur and tibia, of which around 20% presented with knee instability. Around 79 cases were identified during the index procedure and were addressed, and another 15 patients presented during the follow-up and they were treated accordingly. So the take-home message is the high index of suspicion of knee instability in such fractures is very important. The assessment of knee stability immediately after fracture stabilization is key, so that you can identify and address these instability during the index procedure. And also doing a good rehab, getting complete range of movement, and sometimes these patient can present with instability. So identifying during follow-up, and in case if some procedure instability is there, we need to do a tailor-made procedure to have a gratifying outcome. Thank you.